nke bishop na ega digo iyo gogo kaije na nke bishop na ifa digo today na today.
In the 21st century, the guiding principles of healthcare hinges on the following: evidence-based policy making. Today, they don't just make policy. Before they make policy, they have to look for evidence. And those evidence are usually found in publications and research studies carried out across board. And then tracking of health inequities. We have all manner of health inequities, and that is why some countries are failing today. We talk of Vision 2030, moving towards Vision 2030. Some countries already know that they will not be able to achieve that, but in any case, they are moving forward. Healthcare financing in low and middle income countries. Healthcare financing has become a serious issue globally, and you cannot overemphasize the need to tackle that along the way. And then healthcare delivery by skilled healthcare workers. Skilled healthcare workers. And what we consider the skilled healthcare workers, the pharmacists, falls into this group. These healthcare services are not just rendered by ordinary people, but they are skilled people in the sense that they have some things to offer or to do which ordinary people cannot do. And then equitable access to vaccines and immunization, and access to quality and affordable health commodities. If you go to the hospital today, you find out that things are very expensive. Consumables are very expensive. If someone is booked for an operation, you find out that the person should just go and look for about 500,000 and above because of the increasing cost of healthcare commodities. And then good nutrition and mental health. Now, universal health coverage and the link into the SDG 3. Through the universal health coverage, individuals and communities receive quality health care, at no cost or at affordable cost. One of the limitations in our healthcare delivery system today is catastrophic spending. And catastrophic spending limits the ordinary man. They cannot afford to pay for some services. You find out that some people, when they come to the hospital, even at discharge, they cannot pay, or settle their bills. Some of them will quietly leave the hospital because they cannot pay. So this has been a serious limitation as we continue to move towards the 2030. It's made up of good quality services, fees, health promotion to prevention and treatment. In the case of sustainable development goals, the issue of prevention, treatment, rehabilitation, and palliative care is very, very necessary. And some of the indices for measuring health services, are hinged on these elements. And the services of hospital and administrative pharmacists, dot these lines, all these services, the hospital and administrative pharmacies carry them out at different stages. And when people outside look at the pharmacists and they say that they only dispense medicine, I laugh, because there are a whole lot of things they do, and some of these things come in sequence in the course of their practice, as we are going to see later on. Yes. Now it provides healthcare and financial protection to the citizens. One of the things that the universal health coverage does is to provide healthcare and protection, especially to the citizens or the vulnerable. Now you have equity in access and you have quality of healthcare services. So when we talk of equity in access and quality of healthcare services, you find out that in any healthcare institution where you have limitation in this area, there is always an issue. And then in addition to that, we also have financial risk protection. It seeks to ensure that costs of healthcare does not put people at risk of financial hardship.
We've talked so much about universal health coverage, health for all that is accessible and affordable to all. But most persons or most ministries, systems, tend to focus on structures, procurement, drugs, building infrastructure, and very little attention is paid on human resource for health. That's capacity. Now, we do a lot of trainings, but we do very little in expanding the number of health professionals that will offer these services that will help us attain UHC. And that's what I'm going to be looking at going forward. So I just want us to have that context in mind. The topic says optimum healthcare. The optimality we are talking about is universal health coverage. And it just says it should be accessible and it should be affordable, full stop. Well, it has to be available. You have to make it available for it to be accessible and affordable. So that's the optimum point. But what are we doing in these speeches? Just gloss through the emigration, what we call the brain drain thing, or the Japa syndrome. Just go through it. Then towards the end of my remarks, I'll come with strategies that have been put up, either by literature or what I also think as a policymaker. Some of them may not be very palatable, but I want us to brace up because I know questions will come from that point. If we must get a sustainable solution. As Pharmacists has said, emigration, another popular name for it we know is brain drain, isn't it? To Japa. I hope you know there's a remix of Japa now. There is Japa. I hope you know. I'll come to Japa later because we are remixing it as time goes on. But really, what is emigration? Simply put, emigration is a form of immigration. But this time around, highly skilled personnel in large numbers. Please take note of the keywords I'm using. Highly skilled, meaning that if it was just normal human beings moving, nobody will have a problem with it. But this is highly skilled, highly specialized set of persons living in their large numbers from one country. I did not say from one state. Even though we're looking at a state conference, we could say yes, somebody is emigrating from Osun State to Enugu State. But emigration in the real context is at country level. We are moving from one state, from one country to another. But that's not even the issue. Emigration became an issue, or brain drain became an issue, where people started to move from developing countries, highly skilled persons, developing countries to developed countries. Now, people say, why is it a problem? Developing countries, what is synonymous with them? Inadequate, highly skilled labor. And people are moving from that one end of inadequacy. I think in physics or in chemistry, that is not diffusion, isn't it? Diffusion is moving from an area of high concentration to an area of what? Active transport says it is the reverse through a permeable membrane, isn't it? So it's as if we are actively transporting ourselves against maybe a hill or something. So it means energy is needed, isn't it? We are forcing ourselves to move. Now, let me give this background. Please, it's a global phenomenon. Emigration is a global phenomenon. How do I mean? Why do you think countries like Canada keep opening up the space for you to come? Why are they encouraging emigration? Do you know that Canada is also losing high-skilled labor to the US? Most people don't even know. Oh, you think these countries are just so, they like us so much? Canada continues to produce pharmacists and doctors. But those doctors and pharmacists also move to fill the gap in the US. And that's why Canada opens the doors for more people to come from developing countries. But there's a key word. The problem with developing countries is that to get that skill, to be a pharmacist is so cheap. Let me use the word cheap in parentheses. I'm sure you know, to train to be a pharmacist, give and take, even in this current dispensation, 1 to 2 million, 5 years, you are done. Am I correct? Please, am I correct? With 2 million, you can do the 5 years. Okay, let me say in federal. In federal, 2 million should be able, just thereabout. Do you know 2 million cannot even pay for your meal in a Canadian school or a US school for 2 years? You can't pay it, even if you convert it. I want us to understand where I'm coming from. So these guys are tapping from a source of where cheap labor has come from. Who loses? The source destination, the source country loses, which is the developing countries. So you can see where the mindset is coming from. They come over there, they tell you to do some qualifying exams because they know you are well trained. All they just need to do is to set a standard to see whether you can surpass. And when you get that standard, you're already taken up into the system. You are solving their problems and further worsening the problems of your own country. So Canada is also experiencing mass immigration, but what are they doing? They are filling it up back as much as possible. I hope you guys know the concept of input and output. When you have a tank, as you're pouring in water and there is a tap leaking it out, if the rate at which you're putting water inside is equal to the rate at which you're letting water out, nothing remains in the tank. I hope you know. So what people do is either you slow the output even without increasing the input, or you increase the input faster than the output so that the level in the tank will continue to rise. That's where the key problem is. Everybody is emigrating. Everybody has the right to move. The question is, how are we putting policies in place to regulate that movement?
My own view, the fact that Africa needs strong institutions in both public, private, social and non-state actor is rather stating the obvious. Because if the institutions are properly structured, there's hardly any way anybody can come and abuse it. Just like people keep saying that when there's a system, it's always difficult for you to go out of it because the system itself will check on you, will check you. Now, what are the strong views? My strong view is that Africa and indeed Nigeria need strong frameworks of legislations, regulations, rules, legal orders, policies, guidelines, processes and procedures that effectively prescribe and determine what is acceptable, permissible, or can be done, and what is impermissible, what can be sanctioned, and what should be prohibited. The next slide. Now, let's now go to definition of terms. Because we talk about policy, we're also talking about institution, and we're trying to connect this to universal health coverage. Policy is defined as a course of or method of action selected from among alternatives. Before you agree that this becomes a policy, you must have weighed other alternatives and establish the fact that this one that you are choosing is the best. Because every item of the policy is bound to be challenged. So you must be prepared to defend your choice to the effect that it is better than every other alternative. So you don't just make policy because it suits you, because it can be challenged. And in light of the conditions to guide and determine present and future decisions. It is a course or principle of action adopted or proposed by an organization, individual or government, a blueprint of organizational activities which are routine in nature. Well, the law can compel or prohibit a behavior. Policy merely guides action towards those that are most likely to achieve the desired outcome. The next slide. Now, practice. Practice is the application or use of an idea, a belief or a method, as opposed to theories relating to it. It is the customary, habitual or expected procedure or way of doing something. It is the activity performed to produce a known or envisioned effect. Meaning that when you are carrying out a practice, there is an expected outcome. So if the expected outcome is not achieved, then there is a need to also check the method and the procedures. It is an act of method followed with regularity and usually through choices. It means that you can't say, this is the way I do it today, but because I woke up from the other side of the bed, I will approach it differently. No, that is not the way practice should be. The next, now, universal health coverage. These are the three elements in my presentation, which I'm also trying to lay foundation to. Now, universal health coverage ensures that all people obtain equitable and quality health services, improving health and protecting households from financial hardship to obtain them. So you can see that when it comes to defining universal health coverage, like I said, it will come as something that is very bogus, very difficult. But I think we should not allow this to deter us. If you look at all the slides that we have spoken to before now, there are things that we can easily relate to. There are things that we can easily, in ourselves, see the positions we can take to make them happen. But when you come to this, it's not as easy as that because it's quite big. It means that all people have access, is it possible, to the full range of quality health services they need, when they need it, and where they need them without financial hardship. It's also an uphill task. It covers the full continuum of essential health services, from health promotion to prevention to treatment, rehabilitation, and palliative care across the life course. Be that as it may, as big as it is, I think we should leave it as it is. Let's now get to what is within our control. What is within what we can do, the spectrum of what we can do, that gradually take us to this point.
I'm going to start from Pharmacist Olumide Akintayo. The consultancy Pharmacist cadre had been on for over a decade. And we thank God because we have actually come to, at the end of the tunnel, there is light. I just wanted to shed some light on the roles that have been played by PSN, JOESU, and AHAPN. So kindly take us through the roles that have been played and some other things that you feel that AHAPN members needed to understand. Thank you.
If you're familiar with the historical tapestry of issues bordering on consultant cadre, you realize that the PSN itself was the pace setter in a lot of ways. And that's why the first time we actually had an approval of that concept was in 2011. To facilitate that, I mean, we can begin to see some of these things now publicly. To facilitate it in 2011, I remember very well, because you see, the National Council on Establishment, for those who don't know, is headed by the head of the civil service of the Federation. The members are the states, the respective head of service in the 36 states and FCT. So, from what Professor Folabi was actually the head of service at that point, and he was on his way out. He was going to retire in a few days. He had about 1 week to exit, and we needed that approval very badly. The man told us pointedly that there was no way he could summon a council establishment meeting, the funds were not there and all that. So we asked how much, what it was going to cost. And he said about ₦1 million. The meeting was supposed to be hosted by the head of service in Benue State at that time. And the PSN had to cough out that sum, that princely sum of ₦1 million, which was some good money in 2011. The PSN had to pay, and that was how that emergency council and establishment meeting was convened in Benue State. And to the glory of God, of course, that was how we got secured that first approval. But typical of our friends in that famous profession that you know, because they will not have any other professional, have specialized skills or acquired skills, they just didn't allow it to work. And that was why it became necessary that we had to now enlist some other support groups to help us to hold government to ransom. Because from AHAPN, which was in AHAP at that point, to PSN, a lot of letters were written to government, but not much happened. And that was why, like I said, we had to enlist the support of the joint health sector unions. And I must say that the joint health sector unions, and those of you in hospital, you must appreciate that you owe a lot of gratitude to Joesu. The reason is simple. There are too many things, obviously, that you cannot achieve or do on your own. Not because you cannot, you're not qualified to, not because you do not want to, but for obvious reasons, we do not have the muscle, the strength to hold government by the jugular.
I want to go to the registrar. There is this song, if you ask me, who I go ask? Some people have asked me, why is it that our consultants not needed at the pharmacy council? And I said, well, if you ask me, who I go ask? But thank God the registrar is here. And as a rider to that, why is it that the PCN is here to implement the consultancy pharmacists for those people that are already qualified? Thank you, sir.
Thank you very much. Like I said in my earlier presentation, this was an issue we discussed earlier this morning with my colleagues. And when the issue was put on the table, because when the issue of appointment of consultant pharmacist cadre has to be implemented, it has to go through council. And the council have appointment, promotion and disciplinary committee. Usually, when the APDC is sitting, you also have a representative of head of service, and then the director of human resource from the Federal Minister of Health. They are not council members, but they have observer status. Reason being that issues will come up from promotions, which sometimes leads to petition. And for those of us in various institutions, we know that this has happened. Attempt to put this on the table for discussion, particularly from representative of head of service. Their interpretation has been the fact that going into the consultancy cadre require this principle of conversion. It's something that we looked at carefully, and at that time we saw it's not something that anybody would want to just give into. If you talk about benefiting from consultancy cadre, I should want to benefit. I passed my Part 2 fellowship exam in November 2004. That's 20 years now. So I should be interested in that. Now, when this issue came up, the issue of this conversion, principle of conversion, was something that the head of service representative were not willing to negotiate. And when I also came up or became registrar, and it was tested in our institution in a different way, which of course translated to something that didn't look good somehow. An officer who had spent 4 years as assistant director, in error, maybe you could have waited to be promoted to maybe a deputy director before applying for such a thing. Applied to be converted to a procurement cadre, a pharmacist. He was converted. But the head of service insisted that because he was already on the final year as an assistant director, having spent 4 years. He needed to come back to step 1, start all over, to be designated as assistant director of procurement. He even wrote protest to the governing council. So he doesn't want that procurement cadre. If actually that one, they do know that the head of service stood their ground. That the fact that that particular approval has gone through, he can't object to it. So what we did was to encourage him, but make sure that we appropriately situate him in a place where he will get to do his job.
Pharmacist Kamal Nohab, president. Presently, we have our members spread across the various unions. MAU, some are in Senior Staff Association, in NOA, and all that. And of course, putting side by side that AHAPN is actually planning to transform into a registered trade union. So what advice do you have for AHAPN generally? Thank you.
Thank you, my chairman. I think there's freedom for association as Nigerian citizens. And any group of people that find the need to come together to form their associations, they are free to do that. No objection to that. But from your preamble, currently you have your member in particular, the hospital practice pharmacists, spread across several unions. And the essence of joining any union, which the cardinal objective of all unions are one, about your rights, about your welfare, about your better working conditions, and promote your professionalities. So for now, for you to join any union, you must have to define why do you want to join the unions, because there must be a defined and clear goal you intend to achieve as a group. So while you are working towards actualizing your dream for having AHAPN unions, which is right, you must also clearly define which unions can adequately address your needs for now before you get to where you are going to. So my advice first, every member of us, Nigeria has a right to group themselves and agitate for what they want. And there are already laid down procedures and requirements for you to have that status. So that is we move between whichever group want it and the Ministry of Labour, in particular the Department of Trade Unions in Ministry of Health, Ministry of Labour. So if you decide to do that, you can go ahead and present all what you're required to present. And if you satisfy the requirement, we are good to go. But meanwhile, while you are doing that, which option do you have to satisfy your needs is a question you should answer here. You must clearly identify a body that can adequately address your needs before you get where you are going to. I used to use this stronger. You cannot build a house that unfortunately is leaking, and you decide to leave that house because you are anticipating to build a new house. You go to outside and wait. That will be more dangerous. It's better for you to manage the leaked house while you are building the better house to go and enjoy it. So I want to take these positions. Every union has this thing to fight for. But one union may be more unique to near perfect house we are about to build. If you ask me to advise, you are supposed to go to that union that give a near perfect what that have a similarity characteristics of what you are trying to build, depending on where you build that your beautiful house. So now at this stage, I'm sorry to say this, offends nobody. When we meet at Taraba in 19something, when there was a declaration of don't join NUAB, that's when we in KV joined NUAB, because we didn't never join any union before. We have not identified any union that can satisfy our need as a clinical staff, as a pharmacist there. So we're neither in SSA or we're neither with any other union. But when we take a decision with all of us today in NUAB, and because this is a union that has some closer characteristics to what AHAPN or AHAPN has before. So we can use that platform to ascertain and achieve what we want to do, and which is what we did up to date, and is what we are doing up to date. So what we are missing out is this. When there are certain rules in place as an organization, and the rule does not suit you, you may never have a chance staying behind to change it. It is when you have an opportunity to become a full member of that house, and you can decide and also make a meaningful contribution or superior's argument that may lead to change of what is happening there. And that's what we are doing today.
And when I finish, you go no say na me, yeah. As you did the delay.